Yeah. So, did you have a busy day there?
Yeah, it has been. We've had multiple admissions today, a couple of cardiac arrests, in-hospital cardiac arrests. Yeah, it's been a busy day.
Sale is our senior registrar in intensive care.
Hi, everyone.
Okay. He's not far away from finishing his training.
Nice to join all of you tonight.
Is he at Australia, Dr. Subramaniam? You are at Australia?
Yeah, I'm in Adelaide, Australia. I work together with Dr. Sanap in our ICU at the Lal McEwen.
Okay.
Great, great.
Okay,
Sir,
should we keep going?
Sorry,
Yeah,
with your permission, can I start, sir? Just line of
okay.
Oh, so good evening, everyone. So today we'll be starting with our webinar series 5. So the today's topic will be going to be very interesting, and this is on the cardiac output monitoring. And we have a host of panelists and the moderator and the presenter. So I'll just start with the introduction. Today's speaker is Dr. Milind. So Dr. Milind is one of the leading practitioners in Australia. He's attached to 2 or 3 good centers. And the primary place of working is, I think, Lal McEwen Hospital, if I'm not wrong. And he is leading a team of intensivists there. So he'll be presenting to us today regarding the cardiac output, which modality to choose and which is important. And with us today, the other moderator, I'm Dr. Gunadhar. I'm the consultant ICU, Apollo Hospital. And with me, my colleague, Dr. Akhilesh, he's also working as an intensivist in Apollo Hospital, Navi Mumbai. And today our panelist will be Dr. Pramod Guru. Dr. Pramod Guru is the leading ECMO specialist in charge intensivist in Mayo Clinic, United States of America. And with him, the other 2 panelists are Dr. Niranjan. Dr. Niranjan Panigrahi is from Apollo Hospital, Hyderabad. He is also ECMO in charge and intensivist in charge of Apollo Hospital, Hyderabad. And with him, Dr. Aditi Jain. Dr. Aditi Jain is senior consultant and my colleague. She is working with Apollo Hospital, Belapur. And she has basically did her training from the Toronto General Hospital, Canada. And with us, our eminent other panelist, Dr. Amol Kothekar. Amol Kothekar is the associate professor and intensivist in charge, Tata Memorial Hospital. And he is also, his area of interest will be hemodynamic monitoring. So with that, I'm giving over the session to Dr. Milind. And Dr. Milind is going to speak to us regarding cardiac output monitor, and followed by that, we have 15 to 20 minutes of discussion on the topic. And after that, there is a 15 minutes very interesting session by Dr. Milind. So what is the pathway of intensivist and how to enter the Australian system of intensive care practice for the budding intensivist and all the critical care fellows. So with this, let's start the session. Thank you.
Okay. Thank you, Gunadhar, for the introduction. So my name is Dr. Milind Sanap. I'm intensive care specialist. I've been practicing in Adelaide, South Australia, for last 20 years or more. My public hospital attachment is in Lal McEwen Hospital in South Australia, where I'm also supervisor of training for last 15 years. It is a public hospital and it's attached to the University of Adelaide. And I am affiliated with the clinical senior lecturer in Adelaide University. My private practice is based in 2 hospitals. One is the Western Hospital, where I'm the co-director of intensive care unit. And I'm the second hospital, the second private hospital is Calvary North Adelaide Hospital, where I'm the visiting medical officer. I'm very closely associated with the College of Intensive Care Medicine of Australia and New Zealand. And I'm on the panel of examiners for the fellowship exam. So today, I'm going to talk about the cardiac output monitoring in intensive care unit. As Gunadhar has said, after that, I'm going to talk briefly about the pathways to enter in the intensive care training in Australia and how the system works. First is the cardiac output monitoring. So basically, it is the volume of blood ejected from the left ventricle per minute. And it depends on the preload, contractility, heart rate, and afterload. So basically, heart rate into stroke volume is equal to cardiac output. So I'm going to talk about the cardiac monitoring system, what I use in my unit, what I practice, and what is the evidence around. I would also like to know, and I would like to hear from the panelists what they practice in their unit. There are many methods of measuring the cardiac output. An important one is to assess a patient clinically. And then there are invasive methods and non-invasive methods or minimally invasive methods. So it is very important to assess a patient and assess their end organ perfusion to determine the cardiac output. And that's the most important thing. If we think there is a hypoperfusion to the organ, like brain, kidneys, tissues, skin, that means the cardiac output is likely affected. So in terms of the brain, a patient is confused, has got decreased level of consciousness, there is decreased urine output in regards to the kidneys, or rising lactate, or increased capillary refilling time. That's where I'll be concerned about the cardiac output. It is very important to know blood pressure may not correlate to the end organ perfusion. Some of the patients with the low blood pressure can have good organ perfusion, even with the 90 systolic blood pressure, and some of the patients, even with the high blood pressure, 140, 150, may not have adequate perfusion. And also the hypotension may not correlate with the cardiac output, and many patients who are hypotensive, septic shock, they may have high cardiac output status as well. So those are the keys. Now, briefly, I'll talk about the invasive, just to name few invasive and then few non-invasive or minimal invasive techniques, and then we'll discuss what I use more often in my intensive care unit. So these are the few techniques most of us are aware: pulmonary artery catheter, PICO, there is LIDCO, transstitchable echocardiogram, and some of the non-invasive techniques or minimal invasive techniques are esophageal Doppler or the flow track technology. Now, I must say the most common method what I use in my practice is the pulmonary artery catheter. And that is there since long time, and it is still remains the key for the practice for the monitoring of the cardiac output for the critically ill patients. Pulmonary artery catheter, which is also called a Swan-Ganz catheter, is the dye dilution technique used for the determination of the cardiac output, which is done with the thermodilution, where intermittent known volume of the cold saline is injected with the distal thermistor, and that's how we measure the cardiac output. It also helps to determine the pulmonary artery capillary wedge pressure, and I'll go through some of those things. And it uses modified Stewart-Hamilton equation, and modified Stewart-Hamilton equation is depend on the amount of dye injected and the concentration gradient within one cycle of the cardiac output, and that's what is used to determine the cardiac output. What we can measure with the PA catheter, there are a lot of things what we can do, lots and lots. So there are some direct measurements and some are the indirect measurements what we can do. And direct measurements are central venous pressure, we can do right-sided intracardiac pressure or the RA pressure, pulmonary artery pressure, pulmonary artery occlusion pressure, and we can measure the cardiac output. Another important thing, the mixed venous oxygen saturation directly from the pulmonary artery. That's what we can do. These are the measurements we can do. And as we can see, we can get the idea about the left side of the heart as well as the right side of the heart. There are some of the indirect measurements what we can measure with the PA catheter, and those are systemic vascular resistance and the pulmonary vascular resistance. We can determine the cardiac index. We can determine the stroke volume and the oxygen delivery and the oxygen uptake. Those are the things we can measure with the use of the PA catheter. What are the indications? There are many indications to put the PA catheter in critically ill patients. Shock status, any shock status, cardiogenic shock, septic shock, obstructive shock, and generally my practice is someone who is shocked and who is on vasopressor, around 20 of noradrenaline, to determine their cardiac output by some meaning, and it could be likely with the pulmonary artery catheter. There are cardiovascular conditions, complications of the cardiac condition, cardiogenic shock, left ventricular failure, pulmonary conditions like acute pulmonary hypertension or acute on chronic pulmonary hypertension, and then around the cardiac surgery, perioperatively, preoperatively for optimization, intraoperatively or postoperatively for the hemodynamic monitoring. Then the fluid requirement and the effectiveness of the therapy we can assess from the PA catheter. Patients who are critically ill with the multi-organ failure, renal failure, hepatic failure, shocked and profoundly hypoxic respiratory failure, we can use the PA catheter. It can be used for the diagnostic reasons, and it can be used for the therapeutic reasons. And so briefly, we talked about the shock status we can use. It helps to determine the type of shock, whether it's a high cardiac output shock or it's a low cardiac output shock, and also to differentiate between the type of edema, whether it's a cardiogenic pulmonary edema or it's a non-cardiogenic pulmonary edema. And that's where we can determine with the use of the PA catheter. And evaluation of the pulmonary hypertension, again, acute or chronic, and diagnosis of the pericardial tamponade. Those are the indication and use of the PA catheter as a diagnostic tool. And it can be used for the therapeutic reason when a patient of shock who is on high doses of vasopressors, and we can initiate the therapy with the inotropes, and then we can determine, we can choose what we want to use. We want to use which inotrope we want to use. Is there a role for the milrinone? Is there a role for the for dobutamine? Is there a role for the vasopressin? And we can determine the therapy in a shock patient with the use of the PA catheter. Also, perioperatively, management of the unstable cardiac patients is not only the cardiac patients and the cardiac surgery, but the patients who are having surgery for the non-cardiac reason with the cardiac comorbidity, also we can use the PA catheter. And also in the complicated myocardial infarction, with the heart failure, with the shock, and we talk about the cardiac surgery, severe preeclampsia, for guide for the pharmacological therapy and the fluid therapy, burns, renal failure, heart failure, sepsis, decompensated cirrhosis. In many of those group of patients, PA catheter is useful I'm sorry for that. Yeah, PA catheter is useful to as a therapeutic tool, and also assess the response of the pulmonary hypertension to the specific therapy, whether pulmonary hypertension is acute or chronic. if it is acute, if we have started some therapy, we have started milrinone, we have started nitric oxide, whether the patient is responsive to that therapy or not, we can determine by monitoring the PA pressure, pulmonary artery pressure, and that's where the PA catheter is useful. Also, the patient with the chronic pulmonary hypertension, when we need to start them on the therapy like bosentan, sildenafil, we can use the PA catheter, assess their response to the nitric oxide, and see if they are responsive or not, and determine the therapy. That's how the PA catheters can be used. Are there many contraindications? Not really. There are not much contraindication to put PA catheter. And if there is an infection at the insertion site, then always you can use another site. If there is a right ventricular assist device, probably that's the contraindication, but that's a very rare condition. And relative contraindications, which are coagulopathy, thrombosis. Can you hear me?
Yes, sir.
Yeah. So relative contraindications are like coagulopathy, thrombocytopenia, severe electrolyte imbalance. That can be corrected easily. We can correct those and then insert the PA catheter. There are very few contraindications to put the PA catheter. Now, in terms of the insertion of the PA catheter, I'll just briefly talk about the decision, preparation, equipments, and technique. So decision, in my practice, my unit is the decision is at the consultant level. Once we decide to put the PA catheter, that means the patient is critically ill, and that decision is at the consultant level. And the PA catheter only we allow senior registrar to put, or the registrar under the supervision of the senior registrar or the consultant, or I prefer to put myself. Preparation, most of the preparation it's just like the central venous line preparation, so I won't go in details of that under fully aseptic precautions. And the equipments are also exactly like central venous line and additional PA catheter, which we'll see in a minute, and with the Seldinger technique. And this is the PA catheter, which has got, this is the PA catheter, and this is the thermistor connection. And then there are two ports, the proximal infusion port and the distal infusion port, and the right ventricular port. And we'll go through the waveforms in a minute. And this is the balloon inflation port to inflate the balloon of the PA catheter. Some of the newly modified PA catheters, they come with the additional port, and there are thermistor connection, two connector, one for the injection of the saline or the dye, and other is just for the measurement of the value. And there is additional continuous oximetry cable connector. So some of them get with the additional, but most of the time we just use the standard one. So PA catheter goes to the sheath, which is 7.5 French, and this is the sheath, which is the single lumen sheath. But nowadays, the MAC catheter, which comes with the multi-lumen sheath as well. So PA catheter fits in for both, and we can choose any of those. In mostly, I use the single lumen sheath while insertion of the PA catheter, and because there are multiple lumens, you can get anyway. And there is this protective sheath as well of the PA catheter. Now, briefly, I'll talk about how we introduce and the waveforms. Now, the PA catheter is through the central line. You can use any line. So internal jugular vein, left or right, you can choose any of those. subclavian, left or right, and occasionally the femoral vein one can use. Mostly I prefer to use the internal jugular, where the PA catheter just goes smoothly in. And once it is in the right atrium, balloon is inflated. And once the balloon is inflated, then it floats from the right atrium to the right ventricle. And before it goes to the right atrium, look at the waveform in the right atrium. And we'll talk about that in a minute again. And once it reaches to the right ventricle, you will see the change in the waveform. And once it reaches to the pulmonary artery, again, the change in the another waveform. And when it is going in the left or right pulmonary artery, and when the balloon is inflated, you get the pulmonary artery wedge pressure. And this is again the same thing in this slide. The central venous pressure, or the right atrial pressure, right ventricular pressure, PA pressure, and the pulmonary capillary wedge pressure. Very important to know that when advancing the catheter, always inflate the tips from the when the catheter is in the right atrium, so that balloon floats and advances from one chamber to another. And when withdrawing, make sure balloon is deflated, and so that it does not cause the bleeding and the hemorrhage. Never inflate the balloon against the register, but that's where is the risk of the pulmonary artery rupture, which can lead to catastrophic hemorrhage. So it's a rare complication, but as long as we are aware of the complication. And as we have briefly seen, so we can get the waveforms from the right atrium, right ventricle, and the pulmonary artery. And first is the right atrium, and normal right atrial pressures are about 0 to 7, and look at the waveform in the right atrium with the AC X wave, atrial contraction, tricuspid valve closure, and the atrial diastole. And then we can also see the passive atrial filling and the atrial emptying. Can somebody tell me the causes where we can see the abnormal right atrial waves, the increase in the right atrial pressure? The question mainly for the DNB candidates. Anyone? Yeah, speak up.
Sir, I think yeah, one is one choice, or one somebody has put that it is a severe TR, and second is in this atrial fibrillation.
Yeah, okay, yeah, that's good. The atrial fibrillation, we get abnormal, that's for sure. Elevated are the diseases of the right ventricle, like right ventricular infarction, cardiomyopathy, pulmonary hypertension, pulmonary stenosis, left to right shunt, even the pericardial diseases, left ventricular systolic failure, hypervolemia, and atrial fibrillation. You are spot on. There is a loss of A waves in atrial flutter and fibrillation, and the tall V waves can be seen in the tricuspid regurgitation, and the giant Canon A waves in the VT, ventricular pacing, complete heart block, and tricuspid stenosis. So those are the conditions we can get the abnormal right atrial waveforms. Right ventricular pressures, systolic right ventricular pressures are 15 to 25, and the diastolic are 3 to 12. And that's the waveform. Again, we can see the systole and the end diastole. And then there is a slow filling phase. Again, the condition where we can have abnormal right ventricular pressure. Anyone?
Somebody has replied like severe PAH, pulmonary arterial hypertension.
Yeah.
And pulmonary embolism.
Yeah, very good. Yeah. So which can cause ultimately right ventricular ischemia and infarction as well. Increase pulmonary pressure, somebody mentioned, very good, well done. And the pulmonary valve disorders, which can cause increase in the right ventricular pressure. Very good. Then the PA pressures, and and just before we go to the PA pulmonary artery, there is the risk of arrhythmia is highest or greatest, while the catheter is in the right ventricle. So it has to be moved quite quickly, and the technique, how the float is, you have to just rapidly float it like floating a kite, and that's how it goes quickly, not slowly. So just a little bit quick, and then stopping in the small reaction. That's how it goes quickly and floats quickly. One of the technique how we can place it in the right spot in quick period of time. And when the catheter tip passes pulmonary valve, the diastolic pressure increase and characteristic diacrotic notch appears in the waveform. And I'll show that in a minute. And systolic pressures are about 15 to 25. And this is important number to know, because that's how we divide the pulmonary hypertension. And when the pressures are high, the mild, moderate, severe after that. So that systolic PA pressure is very important. And this is the waveform, systole and the diastole and the diacrotic notch of the PA, pulmonary artery. And the causes, it can be acute causes, it can be acute on chronic, and or the chronic. Acute causes we often see in the patients with the ARDS, acute lung injury because of the profound hypoxia and hypoxia-induced pulmonary vasoconstriction, venous thromboembolism, acute on chronic. The similar thing happening with the in patients who already have got the cardiorespiratory problems like COPD, restrictive pulmonary heart disease, and again the chronic pulmonary hypertension. And causes we divide into primary pulmonary hypertension, diseases of the heart like valvular heart disease, mitral stenosis, so lung disease, obstructive or restrictive lung diseases, chronic venous thrombolism, and the miscellaneous condition that all can cause pulmonary hypertension. And this sort of classification of the pulmonary hypertension, which can be the question also for the DNB candidates. Pulmonary artery occlusion pressure, and once the catheter tip has reached the pulmonary artery, then it is advanced until it goes in the one of the branch of the pulmonary artery, and we get the pulmonary artery occlusion pressure. And when it is in the correct position, the balloon should be deflated. And when you deflate the balloon, the pulmonary artery trace comes. When you inflate the balloon, the pulmonary wedge pressure trace comes. And I'll show that in a minute. So pulmonary artery occlusion pressure is equal to pulmonary capillary wedge pressure, which also equivalent to left ventricular end diastolic pressure. It is best captured in the supine position at the end of expiration and in zone 3. And normal wedge pressures are about 6 to 15. And this is the waveform. Can somebody tell me where there will be high pulmonary capillary wedge pressure and where will be the low? Just tell me the high first.
So any of the DNB or fellowship candidates can answer and interact if they want.
If you like, yeah.
So Dr. Saurabh has replied, it is a left atrial myxoma.
Yeah,
Or
yeah.
or mitral stenosis?
Yes.
Dr.
Yeah.
Mitral stenosis, mitral regurgitation, and even left ventricular myocardial infarction.
Yeah.
Cardiogenic
That's
shock.
good. Yeah. Fantastic. Cardiogenic pulmonary edema as well. Very good. This is the ideal position. What I was describing briefly before. That's the west zone 3 position, where the pulmonary artery pressure is more than the pulmonary alveolar pressure, which is less than the pulmonary venous pressure. And that's the ideal position of the PA catheter. This is the waveforms again. And what I was describing, when balloon is inflated, you get this trace, the waist trace. Balloon is deflated, you get the pulmonary artery trace. And most of the causes you told here, so that's very good. Well done there. Can't remember the name who told, but very well done. Okay, so those conditions: left ventricular systolic heart failure, diastolic heart failure, mitral and aortic valve disease, hypertrophic cardiomyopathy, hypervolemia, large right to left shunt, pericardial diseases. These are the causes where the pulmonary capillary waist pressure will be high, and often it is low. Two classic conditions: hypovolemia and the obstructive shock. Obstructive shock can be because of the pulmonary embolism or can be pericardial tamponade. And how it calculates the cardiac output? With the thermodilution techniques, with the fixed method, which is the uptake of the oxygen dependent on the delivery of oxygen and the difference between arterial oxygen and the venous oxygen. And we get the measurement of the cardiac index. Our 2.8 to 4.2 is normal, liters per minute per meter square. And these are the classic conditions where with the decreased cardiac output, systolic heart failure, diastolic heart failure, this GNP candidates, again, got to know this. And this is where we got to know how we are going to differentiate, what are the causes. When we get the information through the PA catheter, how we are going to use in our clinical practice. That is what is important. Decreased cardiac output is in this heart failure, systolic or diastolic, mitral trigger, hypovolemia, pulmonary hypertension, right ventricular failure, cardiogenic shock, obstructive shock. Increased cardiac output is the septic shock, but other conditions which also cause the increased cardiac output is sepsis, hepatic failure, AV fistula, thyrotoxicosis, anemia, very renal disease. Those are the conditions with the increased cardiac output. Complications, if you put more, there are less complications. You get used to. Most of the complications are the central venous line complications, bleeding, arterial puncture, air embolism, thoracic duct injury, pneumothorax, hemothorax, and the delayed complication with the infection and thrombosis. Additional complications related to PA catheter are arrhythmias, misplacement, knotting, kinking and knotting of the catheter we have to watch. That's why while insertion and removal, we have to be very careful. Valve rupture, especially we are pulling the catheter out with the balloon inflated. That's where it can cause the problem. Pulmonary artery perforation for the similar reason, thromboembolism, infection, those are the other complications. What is the evidence? And we have got Sel, who is going to tell quickly the evidence. But it is controversial. It is very controversial. There are not sort of enough trials, and whatever the trials have done, they have not shown the mortality difference. Whether the trials were conducted with the exact correct aim is the question, and that's where we get controversial data. In spite of the lack of evidence, pulmonary artery catheter remains quite commonly used tool for the cardiac output monitoring. We'll go briefly for the other cardiac output monitoring. Before that, Sel, do you want to tell the evidence why use the PA catheter?
Sir, Dr. Narendra has put a remark like one of the trial, like Pac-Man trial.
Yeah, that's what I was waiting, Pac-Man. Yeah, go ahead. Yeah, in fact, that's what we're going to talk about that in a minute. Yeah, go ahead. Who wants to ask the question? Please go ahead with the question first. Gunadhar, what was the question?
So the Pac-Man trial, Dr. Narendra has put a remark that there is no evidence of PA catheter.
Yeah.
In randomized, I think in the, most of the studies, what this was.
Absolutely, absolutely. So, Sel, do you want to answer?
Yeah, absolutely. So certainly no randomized control trial so far has shown any mortality benefit from pulmonary artery catheter use. And certainly the Pac-Man trial didn't show any hospital mortality benefit. And this could be interpreted in different ways. I think it can be interpreted that it can be used safely because it did not increase the mortality. The Pac-Man trial also showed that the PAC, the pulmonary artery catheter, actually altered management within 2 hours of about 80% of the patient's managements actually. And this is looking at titration of fluid or titration of vasoactive therapies. So my interpretation of this is it does have the potential to change management in sick patients, particularly in the early resuscitation phase. And perhaps mortality may not be the best outcome to judge the efficacy of a monitoring tool. After all, it's like an X-ray or like culture results. It should be judged on its ability to provide information to the clinician in order to individualize therapy rather than be judged on the mortality, which is probably better used for judging the efficacy of therapeutics or drugs as opposed to a monitoring tool.
Good discussion, and and this is what classically will be asked even in the exam, how you would critically evaluate the role of the pulmonary artery catheter. So good discussion on both sides. So fantastic. That's very good. And that's how the evidence is. It is controversial. Any other comments, anyone, before we go to the next one?
Yeah, as far as the role of PA catheter is concerned, I mean, I think it is still validated and it is quite useful, provided that you know how to interpret the data that is associated with the monitoring. Basically, we should be able to insert the catheter well, and we should be able to interpret the data. If you are not able to interpret the data well, and if you're not choosing the patient rightly, probably you may feel that it is useless, but it is still a gold standard, and I think it cannot be replaced. Though it is invasive, there are more non-invasive tools available, but it is still a gold standard, and probably it is one of the assets that we have in the armamentarium of hemodynamic monitoring.
Absolutely, that's a good comment, Akhilesh. And in fact, most of the other tools, non-invasive tools or minimally invasive tools, are compared with the PA catheter. So whether the other tools are good or not, they are judged depending on the cardiac output generated by the PA catheter. That's why it is still considered amongst the tools. It is still considered as the gold standard.
So can we just have an opinion of other panelists like Dr. Amol and Dr. Pramod? So what is their take? So do you still they use the PA catheter, or they have replaced the PA catheter with the recent cardiac output monitor like Hemisphere?
Yeah, Achilles, thanks for the question, and Dr. Millen, thanks for the overview. As both of you pointed out, I would say that the trend has been in favor of PA catheter for last couple of years. So it came as the 90s, and then there is a lot of use, and then suddenly it vanished between, I would say that 2010 to 2016, 17. And after the ESCAPE trial, which said that almost like 25-30%. And that's true in our unit too. So because what's happened over the course of last 3-4 years, and that is I'm not sure. So if you see all the talk and all the literature, and in particular to critical care medicine, so there is a phase. something comes up, everybody continue to use, then there is a trial so that there is no value, and then there is a group who will come promote the things is really great, and then people will start using that. So this is what is happening the PA catheter story. So people are thinking that this is, we are misutilizing or be less utilizing, there is a value. So the take home, personally, I feel that it does have a role. However, its role is yet to be defined in a particular way. So that's my take. We do use at least two conditions where, like in our unit, because we are heavy on transplant, we are heavy on LVAD as well as RVAD and ECMO. So there's these populations for the transplant evaluation. If I need to know where I need for the before transplant, yes, we need to have a PA catheter. Similarly, with the recent change in the Opton, which is the US version of the transplant for the cardiac transplantations, and then the Impella use, now we are kind of in a catch-22 situation that you have to have the cardiac index and then the Impella numbers, put it in the Opton, and then suddenly your patient's overall scoring system increases. So that's there. But the personally, if you ask me, like where I do use the PA catheter in the MICU or in the day-to-day practice, so the simplest answer is when I'm completely lost, that you know, I cannot really decide whether this is cardiogenic or septic, or I am already adding one after another medications, and then I don't know where. Like it's kind of, I would say that I'm lost in the highway, or maybe I went to Mumbai once, and you cannot know which gully you are going, and then how to come out to the main street. That's what kind of situation where I use the PA catheter to get the sense. At least you can discontinue or discard some of the things which is not there, and then focus on some of the things. So that's what it is. So I hope I answered the questions what you all really wanted.
So, yeah, Dr. Amol, what is your take?
Yeah, so no, see, I work in a onco unit. We don't have a cardiac patients, so I hearing all from all the speakers and panelists having extensive experience of cardiac cases. So for us, actually, frankly, we have not used PA catheters for many years. What we normally use are invasive cardiac output monitoring using either flow track, pico, or volume view. And frankly, at least for us, we had not found any significant role of using PA catheters in outside of cardiac ICUs.
Yeah, Dr. Aditi, what is your experience and your take? And Dr. Niranjan.
Yes. So, hi. So, like, you know, Gunadhar, you and I work in a cardiac, in a CV unit. So we use a lot of PA catheters as well for our patients. We've not really had much trouble. Yes, I agree that like an X-ray doesn't have mortality benefit, but more information is always, you know, power for an intensivist. And the more information we get from the PA catheter along with clinical data definitely helps us treat our patients. And I think it is a good tool to have.
Yeah, Dr. Niranjan, because you are
Hi.
Yeah.
Thank you, Dr. Milian, Dr. Guru, for sharing so much information. So I work in one of the multi-specialty hospital. We have a big cardiothoracic unit, and I specifically work in medical ICU. Yes, we do use PA catheter kind of regularly in post-operative patients, and specifically heart and lung transplant patients, specifically they use. Coming to critical care, specifically non-cardiac critical care patients, when we see, we have stopped using. To be very precise, I have seen PA catheter near about 8 years back. Once I was working in Gangaram Hospital, they were using in medical ICUs, but it's a kind of stopped. Now, yes, it might be bias, or might be because of lack of the trials coming with positive result in critically sick patients, and probably other minimal invasive or maybe less invasive techniques are available. So medically or critical ICU, my decision will be tilted towards minimal invasive or non-invasive. But yes, in cardiac or cardiothoracic ICU, we do use regularly the PA catheter.
Thank you. So I just have one what to say. Basically, whatever the cardiac output monitor we have devised, basically the bias and the accuracy has been compared to the standard gold standard this cardiac output monitoring by the PA catheter. So I think it is one of the good modality. Probably once one know how to use it and in what circumstances and what situation it has to be used. Yeah, thank you. So Dr. Milind, we can proceed, sir.
Yeah, good comments from all the panelists. Fantastic. Vishy, are you there? Do you want to comment anything? He's one of my colleagues.
Yes, Milind.
Yeah, go ahead.
Look, actually, it's a wonderful. I think many of the panelists and the senior clinicians have given opinion. So my take will be the PA catheter currently across the evidence, if you see, they're being used in cardiothoracic surgery related stuff. And in medical non-cardiac surgery patients, usually it has not shown any benefit, but however, to guide the therapy, it is commonly used. Many times we need, especially if the patient is having pulmonary hypertension, patient is having cardiogenic shock, you want to titrate the therapy, I think I would use the PA catheter. That is one. But units, some of the units, you prefer other devices like Pico catheter, Flotac catheter, and all that. That is also fine. But PA catheter has got distinct advantage of therapies because it gives pulmonary occlusion pressures and all that. So it has got still a role, even in non-cardiac surgery patients, and it will be used, and every trainee should know how to interpret, how to use. The more you interpret, the better. I think you will be enjoying it more and using it more. If you don't interpret it, then you feel it is useless.
Excellent, thank you. Good comments. So we'll proceed now. So another thing what I use is the Pico, and I use Pico as well plenty. As I said before, mostly every person, every patient who is shocked, who is on noradrenaline, about 20 is sort of my threshold to get the cardiac output monitoring, either some or other technique, either the PA catheter or the Pico. And I have plenty of Pico as well, particularly sort of if there are junior registrars around and not enough experience to put the PA catheter, then we go ahead with the Pico for time being, and then get the PA catheter done first thing in the morning. So again, most of the indications are shock patients, sepsis, trauma, pulmonary edema, acute lung injury, ARDS, burns, and any condition that requires assessment of hemodynamic and volumetric function, we can consider the PA catheter. What it requires is only the central line, which most of the patients will have, and the Pico line, which is the artery line, basically the long artery line, which can go in any of the axillary, brachial, femoral, or long catheter in the radial. I use only in the brachial or the femoral. Only those two arterial lines. I use those when I'm putting the Pico catheter. And so it has thermistor tipped line and CBC line. And look at this. It correlates strongly with the pulmonary artery flow catheter readings. So it has compared with the PA catheter and standardized. And cardiac output, what we get, it's more or less the same with the Pico. Now, I'll show what we get through the Pico and what we don't get with that, okay, compared to PA catheter as well. And it uses two physical principles. One is transpulmonary thermodilution and the pulse contour analysis. I will just, I'm very mindful of the time as well. We're already 49 minutes. What it gives idea about the preload, which shows the global end diastolic volume, intrathoracic blood volume of the 4 chambers, plus the pulmonary vessels, stroke volume. So it gives idea about the preload. It gives idea about the contractility, which gives the information of the cardiac function index and global ejection fraction. It gives the idea about the lung functions in terms of the pulmonary edema, pulmonary vascular permeability index, and extravascular lung water. So for the lungs, and it gives idea about the afterload, systemic vascular resistance. So it gives reasonable data. What it doesn't give idea about the right heart. It doesn't tell us any information about the right heart. It gives a good idea about the left side of the heart, the contractility, preload, afterload, and not much information on the pulmonary pressures. And many of the critical ill patients have the right heart issues and the pulmonary hypertension as well. LIDCO is another device. I must say I don't use that, and it requires the similar artery line plus or minus the central line. And again, reasonably good calibration with the PA catheter. But the limitations are there is no optimal signal in arrhythmias, patients who have the balloon pump, severe aortic rigor, or if the change in the systemic vascular resistance. That's the limitations. Flow track also came in the middle. As Dr. Guru commented, few techniques became popular in last decade. They came for some time and went away, and less invasive, and but the cardiac output is underestimated compared to the PA catheter. So it has gone out of favor. Esophageal Doppler is another one which can be used for the continuous real-time monitoring, and the shift in the frequency of the reflected sound can be seen, and wave changes proportionally with the change in the velocity. Obviously, there are some assumptions in that, and what the assumptions are: 70% of the blood enters through the descending aorta, and the blood flow is uniform and maximum, and the cross section is constant, which probably every assumption may not be right for the critically ill patients. You can get reasonable information about the left heart, not on the right side, and can't put the esophageal Doppler with the patients with the esophageal comorbidities like varices or esophageal pathology, patients who have the balloon pump or the severe coarctation as well. And again, patient has to be intubated, probe has to be very close to aorta. It depends on the operator. There is a significant learning as well. So there are a lot of limitations for this. Now, there are a lot of colleagues who work in cardiothoracic center. I think so. Transesophageal echo also is coming, particularly in the cardiac and cardiothoracic surgery, and some of you who work more in the cardiothoracic center would be able to comment more. So transesophageal echo, a lot of cardiac anesthesia is used actually during the cardiac surgery, and advantages are transducer is 2 to 3 millimeter from the heart high resolution images, and so quality of images what we get is very good, and that's why we can visualize left atrial, mitral valve, left ventricle, pulmonary valve, and aorta quite well, and it's quite away from the surgical field, so it doesn't interfere with that. Disadvantages are injury to the esophagus, perforation of the esophagus, and needs special setup and needs expertise. Those are the complications, particularly injuries to the esophagus. Rarely, if somebody shoving in, the splenic injury can happen as well. Are there many who use the esophageal transesophageal echo? amongst the panelists?
Yeah, I think Dr. Rahul wants to speak. Yeah, Dr. Rahul. So I think, sir, we can just finish up the talk and then take up the questions.
Yeah, sounds good. Yeah, it's almost finished actually. So other methods, Vigilio came. I have used Vigilio. It came about 5 to 7 years back. And Dr. Guru said few things came, went back like those. Vigilio came and disappeared in a couple of years actually. And it was just the artery line what is required to get the cardiac output. And I think company stopped using that. And Edwards, I think they were the one, and they only have again started with the EV1000, and again only requires artery line and vigilance more or less the same. Again, very minimally invasive. Hemisphere, they just use the fingers tip and similar Sterling system to determine the edema. I don't use any of those. As I said, I have used Vigilio, and after that, I have not used the EV1000. But those are in the market available. None of them is perfect. Each has its own advantages and disadvantages, and we need to decide what tool is useful for which patient and what we are going to use. With that, I might stop. I would like to say thank you before I open topic to everyone. This is the South Australia. This is the wonderful city of Adelaide, and this is the outskirts of the Adelaide. It's a handoff. It's a German village. I just went for the lunch last week there. It's looking pretty because we are in the autumn at the moment, and this is the beautiful Kangaroo Island. So I'd like to take opportunity to invite you and welcome to all of you to South Australia at some stage. Thank you. Topic is open for the discussion.
Yeah, thank you, sir. So basically, after this discussion of 10-15 minutes, so I think, sir, again, there is a small 10 minutes of talk, how to reach Australia, and I think how to practice in Australia. So that is what Dr. Milind is going to tell us. And before that, I think let's pick up some of the questions. So the first thing is regarding the PICO. So I want to ask everybody's opinion, like Dr. Pramod, Dr. Amol. So still PICO are being used in your units?
Amal, go ahead.
So we often use PICO or volume view in our unit, but not for all patients, only for the patients who are not managed. So it's like a last tier of our hemodynamic monitoring. So all patients in ICU who are on vasopressors, they have arterial line. And then afterwards, if you have the patient cannot be managed with initial only arterial line and resuscitation, they need vasopressors. If they need high vasopressors, then we choose between either a flow track or PICO. And someone who has a bad lungs, we have less margin of safety for giving fluid boluses. We prefer to use PICO or volume view, which gives us additional information of extravascular water, and which helps us in deciding between the fluid and both the benefits and risk of fluid boluses.
Yeah, Dr. Pramod.
Yeah, I think I completely agree with Amol what he said. The practice is exactly similar here. We still use the flow track in our unit on both the medical as well as surgical side. And to be honest, again, I might be sounds funny, and I hope there is no surgeons, or I'm not disregarding anyone's expertise or everything. So I feel, each physicians or surgeons have their love for one versus other kind of device. And then that love is like, it's just so like unique love. They don't want it to go away, even if you keep bombarding them that this is not, but they'll come back there. I don't want you to listen. Why don't you just put that? So in that case, you don't have any choice. And then I believe all of the intensivists, even we don't have any choice, because we are the people who kind of keep everybody's happy, as well as do our things to keep the patients happy and the family happy. So in this midst of keeping happy everyone, so we choose one versus other. I'm not sure what is right, but for the intensivist as well as medical practice, you will see that depending upon what phase of the cardiac monitoring or what things, there are all these things involved. So that's the so-called philosophical and practical aspect of the care. And then if you think about the real physiological and where you need to do that, yes, if you are really struggling with a PA catheter, or you already have the PA catheter and then it developed complication. I'm not sure, like, I just wanted to hear from other people what is the complication rate. So personally, I have seen that even if people claim that it's less than 1 to 2%, 3% of complication rate, PA catheter is not that simple, and there are situations where, if the PA catheter inflated and bleed, the only place the patient can be salvaged is the OR, and it's in the middle of the night, forget about it, So I have seen this kind of things. Like if you see once, you'll never forget that, it's not just simple. It's not floating, it's not simple. And then the same is that, if there is a torrential TR or MR, or, like a congenital abnormality of your heart, or they have already previous surgery, or they have 2 or 3 leads on the, like more and more we are getting people with many, pacemaker and all. So it's very difficult to float. And then we are, at least in our unit, we are utilizing the bedside fluoro to float it. It's difficult. So the bottom line is, to short the answer, yes, we use, but it varies. It's not a routine phenomenon, to be honest.
Yeah, what about Dr. Aditi? What is your take on this all this volumetric based cardiac output monitoring like PICO and volume view, and with comparison to echo?
The advantage that PICO and FlowTrack have over echo is that it's a continuous monitoring. With echocardiography, we can definitely measure the cardiac output, but we won't get and look at the right heart as well as the left heart. However, it is difficult to get continuous values with echocardiography. Another thing with echocardiography is it's very dependent on the person doing the echo and their skills to get the right images. Things like, the right angle at which you're measuring it. If it's more than 20 degrees, you can get wrong values. If you're measuring the VTIs in the right, at the right position with the closure click and not the opening click, that is important. Where you're measuring the diameter of the LVOT is important. So these things are very prone to mistakes by the same observer or various different observers. So that's the limitation for echo. Otherwise, echo is easy, absolutely non-invasive, and good to do. And it gives us information of both sides of the heart as well. It does definitely have these limitations. PICO and FlowTrack are more continuous forms of information, and we do use them in our transplant patients as well in our unit, as you know. And again, like it was recently just said, that it depends on the comfort of the operator, of the intensivist using it, and how good they are at interpreting the results. I think that is what ultimately should matter. There's no sense in having a device and the ICU team, the nurses, the doctors not knowing how to interpret the values.
Correct. So, Dr. Niranjan, I think your center has many number of ECMO cases. So, if a patient is on ECMO, what kind of cardiac output monitor do you choose? ECMO with IABP and other extracorporeal therapies?
Yeah, thank you. So, before answering hemodynamic monitoring in ECMO patients, I would like to add a little bit. In our center, for non-ECMO patients, specifically critically sick patients, so yes, of course, we know the Vigilio system once upon a time we are using so frequently. We are not using that frequently, but the volume view we are still using, though it's based on the same principle again, and the fallacy is around 30 to 40% time the fallacy can come. But sometimes we use the combined, like the 2D echo as well as the volume view specifically. So the stroke volume, of course, it can underestimate, but probably the volume variation once the patient is paralyzed, put on adequate volume, tidal volume. So sometimes it's a dependable variable. So that we have seen. And coming to 2D echo parameters specifically, yes, it is user dependent, but the learning curve is very stiff. It doesn't take much time. Specifically, even with the newer trainees, within 1 to 2 months, we can train them. So I don't ask my trainee to see the complete heart or the ejection fraction even. Simply, I train them to check the 5-chamber view, to focus on the either before or the after the aortic wall. If they are putting on the LVOT, they can measure the LVOT VTI, and it might be 15 degree, 20 degree, or 25 degree also. Now I ask them to see the leg raising, pre-leg raising and post-leg raising in same position, the VTI, either it's a aortic flow VTI or it's a LVOT VTI. So once they keep the position same, that gives us a reasonably acceptable idea about the cardiac output increment as for the leg raising. So kind of we have standardized that in our unit, but it's not a single parameter. I have made, like, even my resident, if they are in the night duty, they are clueless what to do. I simply ask, okay, you check the VTI. Sometimes if they are senior, they will tell me everything. Okay, the LVOT diameter, VTI, they will tell me the output, everything. But at least minimum they will check the VTI, pre-PLR, post-PLR VTI. They will tell VTI is less than 15, less than 10. Easily you can go and give fluid. If it is more than 25, of course, there is no point. So that's the kind of standardization we have made. We are more depending upon the echo, though it's user dependent. So that's the thing. Now coming to the ECMO patients specifically, yes, if a patient is on VA ECMO, again, it's a big puzzle. Okay, what we are going to use. So now there will be differential pressure in the upper limb versus the lower limb. If we are cannulating the vein, again CBP is gone, right arterial pressures are gone. PA catheter rarely we use with the VA ECMO. So we depend on the radial arterial pulsation, and specifically we use volume view parameters when we use for VA ECMO. VV ECMO is same as other non-ECMO patients, so that's not a problem. But VA ECMO specifically we use the volume view. But I would like to know from other panelists, like what kind of parameters specifically Dr. Guru and other people. Of course, in Australia they will be using many other, specifically in VA patients.
I think Dr. Guru can answer because he's done in many number of ECMO cases.
Yeah, thank you, Niranjan, and thanks, Guna, for the questions too. As he pointed out, so if you ask me, one thing to remember that there is no, I would say that the numbers you get with a PA catheter in ECMO patient has no meaning at all, period, because it's completely screwed up with the differential flow in the two system. So you cannot interpret that. So and in the same way, so the number or the specific number we always think about for a normal or standard patients with the PA catheter doesn't apply to ECMO patients. So it has no meaning. So in the absence of that, I don't really, if there is a catheter, I'm fine. I don't use at all. I don't promote using. Rather, the specific things, in particularly if you are in the VA ECMO patient, as Niranjan pointed out, that if the VA ECMO patients, two things you will need to know: whether the aortic valve is opening or not, and what is your pulse pressure, like is it how you are monitoring that. So for that, if you have a atrial line and then echocardiogram, or like the TE or transthoracic, depending on which situation, that's well enough. So that's what the prevalent practice in our center, to be honest.
Actually, we are also doing this transplant programs, cardiac transplant programs. So in most of our cardiac transplant or heart transplant patient, we are now started using the hemosphere, because the Edward Life Science, I think the Digilio monitor and the CP1000 is now going out of date. And they have come with this newer monitoring devices, that is the hemisphere monitoring, where you can read the pulmonary vascular resistance. So this is, we found this to be a very good monitor, and almost means most of the hemodynamic parameters you can obtain easily and smoothly. So you have any experience on that, the hemisphere, the recent generation monitor?
Yeah, we again we have the Edwards hemisphere. We do have. So yes, at the end of the day, when you are in this complex patient scenario, like for example, all these people in your transplant unit or ECMO unit, so the mind need peace. In order to have the peace, you need the number, because if you don't read the number, then you are always in tizzy. And then the same is also for the other people, those who are at the bedside, in the nursing, everybody wants to have a number in that, because that's fixated, and then they wanted to have it. And we all need that kind of thing. So, but the take-home message, I always say that if I don't want a single number, I want the number so trends as well as what are the other scenarios. So the most and the best person or best scenario which can teach you is the patient's overall clinical condition, where you stand 4 hours back, where you stand right now. Because the reason I'm saying is that if you put a PA catheter or with this, there will be always a number. What to do with the number is God knows, because there will be some abnormal numbers all the time. Do you really wanted to address that abnormal number, or just see the global picture of the patients that, like, yes, I was 4 hours back when the patients come from the OR, these are the things I came across. Now with the interventions, I'm kind of comfortable, and then we'll see what's happening. So just chasing the number doesn't help, but having a number trend does help. So that's what it is. Like, there is not a fixed parameter to really follow. You follow what is appropriate according to the patient just in front of you, and then the device you use, what is the limitation of your device and what is the limitations of your overall patient condition. That's what will give you the best picture.
So Achilles, what is your take on
wonderful. I have one question to all the panelists. I mean, we are moving from invasive to non-invasive, and pulmonary artery catheter in selected group of patients is quite vital if you have good understanding of the parameters that are to be elicited. So I would like to ask the panelists whether the non-invasive tools are equally effective, like newer techniques, bioimpedance and bioreactance have been well validated, and a lot of studies are there, and it has been launched. I would like to know from the panelists whether you would agree with these new devices to be a good additional tool, or should we completely rely on the existing tools. I know the innovations are always better for the betterment of the patient's outcome as well. So I would like to know from you all whether you are all using bioimpedance and bioreactance as a tool for cardiac output monitoring. We'll start with Dr. Sanap and Dr. Guru and Dr. Niranjan and Dr. Aditi. You all, please, one by one.
Yeah, look, so I'll come to your question, and somebody just asked there the comment on the pediatric as well. Okay, so a lot of those.
Dr. Sakuntala, she is my teacher. So basically, she is a practicing cardiac anesthesiologist in Sion Hospital. She is the professor in charge. So she wants to know the good cardiac output monitoring system for a pediatric patient, particularly pediatric cardiac surgical patients.
Yeah, sure. Look, I don't have much experience of the pediatric, I must say. I have, and the newer tools also, we don't use the newer tools. But what I would say is the data, most of them is still not completely validated. Whatever the medical rep, they come up with very small papers and number of patients. What we have not discussed, and what I use, one more thing quite often, is the central venous oxygen saturation. Most of the people who have the central line, and I use their central venous gas every 4 hourly, and that also gives the quite good trend what the central venous oxygen saturation is, and the the determinants of the central venous saturation is one of the most important determinant is the cardiac output, along with the DO to VO2 ratio. And if we have the oxygenation is good, delivery of the oxygenation, if the hemoglobin is optimized, there is no hypoxia, then almost it gives direct indicator of the cardiac output. So if I don't have the PA catheter, it's a night time, we don't have time to go, their junior registrars or PICO is not used. I just tell them to do the serial central venous oxygen saturation. And probably I would use that. And that is something I find very, very useful in the clinical practice as well. And it is often underutilized, underestimated. And and there is a central line. So why don't we just use that, So this is what I would say.
And I think the answer to Dr. Akhil's question, the bioimpedance.
As Dr. Sanup has raised the issue, like central venous oxygen saturation is a good surrogate marker of tissue perfusion and probably the indirect marker of cardiac output monitoring. And it is quite equivalent to a mixed venous oxygen saturation with a difference of around 5 to 10 of that. But I think we also should have an understanding that mixed venous oxygen saturation gives you the perfusion of the whole body, upper part of the body and lower part of the body. Whereas central venous oxygen saturation will give us the idea of perfusion of upper part of the body. So, but do you still agree? I mean, if I have a patient who is having wound in the lower limb and lower part of the body is affected and the perfusion is compromised, in that situation also, would you be completely relying on SCVO2 or would you use other surrogate markers? I mean, this is
not completely. If I have the other tool, definitely I would go for the other tool, But many times what happens, the pulmonary artery catheter is not the resuscitation line. It's always, it comes later. The resuscitation lines, the cannula and the central venous line, And then you put those lines, start the resuscitation of the patient, go and have a cup of coffee, come back, and then decide the PA catheter insertion. Check the coagulopathy, check there is no contraindication. So it never goes in that rush, how the central line goes in. So meantime, till the time I have got other tool available, I will definitely use the central line.
And important here is the trend of probably SCVO2 is also very important here.
Yeah.
And about bioreactance and bioimpedance technique.
I can cut. So sorry, Milind, you want to?
No, I haven't used. Go ahead. Please go ahead.
Yeah, I'll just comment two things about what both Milind and Achilles pointed out that, and what we are discussing here, it's not just a single number, in the absence, if you have everything, so use everything and correlate. If you do not have everything, then just use whatever available and easily available, and then go back to, so I always teach my resident fellows as well as my colleague and then everything's that, always go back to the patients whenever you have a number. So don't treat your computer because you got a computer and then you got a number, just don't go to that. So go to the patient and find out where you stand and then come back. So that is the role of SBO2 for sure. That is the role of PA catheter numbers for sure. There is no question about that. To answer your question, bioimpedance as well as spectrospirometry right now, they are not for the prime time because that's not being validated with significant number of people with a patient-specific outcome improvement. So that much more needs to be done. That is like, I do have a personal experience with the utilization of bioimpedance. Went back in like 20 years back when I was in PGI Chandigarh, a group of hemodialysis patients to see what's their volume status. It's a good curve. AOC curve, like my senior who did a thesis, the AOC curve is 0.6, 0.7. It's a pretty good, but it's not prime time yet, because that's number one. Number two, there is things like the oral spectral microscopy, like diffuser. That's a pretty nice thing. So when I was in training in Rochester, we did have the microscopic scenario. You put the patient and then you see how the the cells move through the vessels in the oral mucosa as well as tongue. That's pretty nice, but it's still in very primitive phase. It's not prime time, but the future seems to be kind of more promising, including all of these things. And then, like, I saw one message in the chat about the role of echocardiogram and everything at this era. There is a school of thoughts, even the entire institution across the United States, at least in the sense that we should throw the stethoscope and buy a pocket iPhone as well as echocardiogram for all the medical students as well as practicing physician. That's what the future is probably, because it's just, you don't need to be an expert on capturing the things. You just need a one shot, like picture, a good window to do that. Even I'm not bragging, like there is an NEGM paper for us. We say that how do you capture the image through the echocardiogram. So you just need to that, like teach them what's there. The basics can be like whether the heart is functioning well or the heart is not functioning well. Is there any pericardial effusion or no pericardial? The half of the cardiogenic shock is in your hand right away, and then you go move wherever you wanted to. And then also teach them that, like I wanted to like discuss and get the other panelists' opinion. You think about that. The PA catheter give you a static measurement. If it's not a dynamic measurement, what you give the PA, pulmonary capillary wedge pressure, doesn't really predict the fluid things. So what is happening over the last 3-4 years? People are jumping to the PA catheter and giving the fluid as per the PA catheter value, but that's not the way you should use it. So it will give some numbers. Please, like, integrate all the patient's clinical status before you intervene anything. That's my take home.
Yeah, and most of these volumetric based cardiac output monitors, like the transthermodilation technique like PICO or volume view, they have a high chances of errors, because and when there is a right heart failure or there is a right heart dysfunction, I think you cannot completely rely on them, and the biases are many. So that is why it has to be an integrated technique, like along with echo, you have to interpret along with some form of non-invasive or minimally invasive, particularly the minimally invasive cardiac output monitor like the flow track. You have to see the trend. I think that is the message you want to convey, right? Yeah.
Yes, absolutely. I mean, I think we should not just be completely, reliant on the existing newer advanced monitors, but we should not forget our clinical tools, your laboratory parameters. Lactate is also still a good marker of perfusion, probably. And and then SCVO2, as Dr. Sanap has rightly said. And I think there is one more monitor. I mean, if we can use PCO2 gap, can also be an additional tool to help you with the perfusion cardiac output monitoring. And then these non-invasive techniques like ultrasound and cardiac output monitors like 2D echo and flow track, these are all additional tools. They can be used together to get the complete picture of the patient. We can't be completely relying on one tool. I have one question. Are we using PCO2 gap as a monitor for patients? Adequacy of perfusion and cardiac output monitor. I think Dr. Amol must be doing it. One of the delegates has asked this question: are we still monitoring PCO2 gap as a surrogate marker of cardiac output and perfusion? Over to you, Dr. Amol.
Yeah, so we use PCO2 gap frequently. No, I've not said frequently. Sometimes, mainly. So mainly, we for resuscitation we're using assessment of fluid responsiveness to the fluidobolus we check, and the PCO2 gap or lactate, SCVO2, all these are downstream parameters that we're using for adequacy of cardiac output, because just having one number of cardiac output is not going to make any sense. We need to correlate it biochemically. So obviously one of them is PCO2 gap, other is SCVO2 and lactate.
Yeah, so Dr. Deepak from Hyderabad, Apollo, he has also rightly put in the chat box that the serial lactate measurement and the capillary refill time is one of the important surrogate marker of the good cardiac output. And this is one of the trial called Andromeda shock trial, which has also proven that. So most of the times he is using this, and I think the results are quite reliable.
So capillary refill time looks very interesting, but you need to train your nurses to how to do it. It's not a very easy thing to, it's, no, it is easier said than done, I would say. Like lactate measurement, any technician can do, or even PCO2 gap, anyone can do. If you're relying on CRT or your resuscitation, you need to be very sure what you're doing.
So there is subjective variability to it.
Absolutely.
A lot of subjective variability.
Regarding lactate and PCO2 gap, once upon a time we were depending, but those are like add-on values. So particularly in medical issues, there might be so many other reasons apart from hypoperfusion, the cause behind the lactate increase. Yes, of course, in trauma, hypovolemic patients, particularly upper GI bleed patients, lactate is definitely a dependable parameter. And PCO2 gap, we really don't use in our unit. And other units, I know they were using the PCO2 gap as a marker. Those things should be used in combination with like at minimally invasive or the non-invasive cardiac output parameter as the surrogate markers, definitely.
And
yeah, please. Yeah, go ahead. So I'll just add since like to the CRT as well as lactate monitoring. So one thing I can tell you that because I'm always pulled into this ECMO business. So I do monitor the serial lactate, and I'm really fixated on the serial lactate. If I particularly instituted VA ECMO in a patient, whether peripheral or central VA ECMO, and the lactate is high, and I have a good flow, and the lactate is not clearing, you have to scratch your head all the time. There is something is missing. So the lactate is very important for me in the initial 24 to 48 hour period in that group of patients. I always wanted, if their lactate is not clearing, you have good flow, that is something wrong. So be careful about that. Yeah. That is the other thing is about the capillary refill time. So according to the Andromed trial, so it's a fantastic trial, and then the entire group needs to be congratulated what they did. But in the same way as Milin pointed out, and then Amol and other pointed out, that you need to really train and then have a objective measure of the how you measure, how we interpret. Because if you cannot, it's always wrong. So then you are lost. But yes, at the bedside, it's a very useful tool, initial in evaluation, because obviously if you have a picture of your forest curve, cold, calming, or dry, hot, then that's what it is.
I would like to hear from Dr. Aditi. She is working in a cardiac unit. So what is the best cardiac output monitor probably in the operating room? So if she can comment, because most of the monitors, they don't work when the chest is open. So what type of monitoring system these surgeons they use usually, which is reliable?
Our surgeons mainly go for PA catheters, from what I have seen, and the chest is open. Again, I'm not an anesthetist. I'm an internal medicine background, so I'm sure my anesthetist colleagues may be able to shed more light on this. But since I have the mic, I'd just like to point a few things. When it is, I know a lot of people are saying that we should replace the stethoscope with an echo monitor, an echo probe. Yes, it is a very interesting, and nobody in the world would be as happy as me if that happens, but there is also learning curve with that. And what I would like to also impress to the students is that even if it doesn't, you have to look at not only the image. If your patient whose ejection fraction is 10% and is in shock, doesn't mean that they wouldn't be fluid responsive, especially if they had diarrhea or bleeding. So always dynamic measurements of fluid assessment would be better. You know, a lot of times if a novice would not be able to differentiate between a hepatic vein and an IVC, or I have seen so many of our own residents be able to differentiate between an aorta and an IVC. So a lot of epicardial fat and pericardial fluid. So there is definitely a learning curve, and in the wrong hands, any of these machines can give us really wrong information, especially in the middle of the night when we ourselves are not there to see the images. So for all the seniors who ask for echocardiography or any other information, I would encourage them to ask their juniors or their residents registrars to send images so that you can yourself assess whether the images, whether what they're doing is right. And again, a low cardiac output doesn't mean that they don't have other reasons of shock. A chronic heart failure patient can have various other reasons for shock.
Yeah, thank you, Aditi, for the last sentence. Like, that is very important and very pertinent to pass the message to the trainee, because I would say that, as you mentioned, there is nothing called a single number for cardiac output or cardiac index. It varies from every person to every person and every different situation. Do not just focus on that 2.1 or maybe 5 liter, whatever you can say that. Then you are done. The patient is done and you are done. But thank you for that. That's a nice take-home message.
So probably the experience is much more important than the exposure. Yeah. So, and one should have a high index of suspicion and a good clinical sense, and have a good sense of interpretation, and have a good sense of this clinical acumen to interpret those results. Then only it will improve the patient outcome.
Bedside clinical signs and symptoms would never be replaced by, no matter what technology comes in. They can always help us, but our, going by the bedside, touching the patient, examining the patient is always going to be our best tool as physicians for eternity.
Dr. Jain, you will be making a lot of enemy outside as well as inside your hospital, I believe so.
So, Gunadhar, may I add one point about chest? So you said, what was the question about the open chest and cardiac output monitor?
Yeah. So most of the cardiac output monitor, actually, they don't work when the chest is open.
Because so about the cardiac surgery or lung surgery?
Cardiac surgery.
Okay.
So I think transesophageal echocardiography can be a good tool to have a good assessment.
But you're talking about on bypass, right?
Yeah, or either on the bypass, or sometimes like the beating heart, where the patient is not on the bypass, by the bypass. Okay. So when the chest is open. So in those cases, I think the trans-thermodilation technique based cardiac output monitor.
No, I don't see a reason why a trans-pulmonary thermodilation should not work. It should work. Only point is you don't have heart-lung interactions the way you have in a closed chest. So what your PPV, SPV, they are not going to be reliable. But yes, I don't see, if there is integrity of circulation is intact. Let's say you're doing a bypass on off pump. I don't see any reason why your cardiac output, whether it's your PSC or your flow track or your volume view, I don't see a reason why it should not be reliable.
Good comment.
Yeah. So basically the thing is that in the trans-thermodilation technique, so the thing is that when there is a increase in the pulmonary congestion, or there is a increase in the circulation time, or there is a increase in the hydrostatic pulmonary edema, those cases the fallacies and the reliability is less. So
in that case, we should not use in ARDS patients, right?
Yeah, so that is why the most of the times this volumetric based echo, your cardiac output monitoring don't work properly in the ARDS patient.
So, I mean, probably they mean to say more about the PPV and SPV.
Yes.
Like it won't be exactly correct, but it's we never want a number. We want the trend. So in that way, it will be still working. It will not be working to the optimal, but we can still extract the data.
One more thing, yes, I want to add that there's a difference between accuracy and precision. So, it may not be accurate. So if your real cardiac output is 5 liters, it may show either 4.5 or 5.5, but it will be consistently having the same error, and it will be precise enough to give you a trend which you can help in titrating your therapy.
Absolutely. So the trend is more important in, I think, in such scenarios.
Yeah, in that way, in terms of tweed assessment, when we go for the stroke volume variation, when you use the Vigilio monitor, so it might underestimate the cardiac output. Yes, we agree. But I agree with Dr. Amol. The same amount of error it will make either end of inspiration or end of expiration. So the stroke volume variation might be a dependable entity. So even if it underestimates the stroke volume per se. So so that's the reason sometimes we depend, particularly when very, very sick patients, specifically cardiogenic shock patients, when they land up in some sepsis, when it's like a mixed shock, when we are not sure it's a clear cardiogenic or a vasoplegic shock, we use that parameter Even the stroke, even the peripheral vascular resistance also we use. But again, the dependency is questionable.
Yeah, and the same thing like the arterial pressure or the pulse, the pico, your what is called the arterial pressure based monitoring, like the flow track also sometimes is showing a false value when there is a shock. It is because it depends on the arterial nature of the pulse wave and the compliance of the system. So when the compliance is not good, like most of the cases where the SVR goes down or there is a shock state, most of the times you will get a very falsely wrong values in this flow track system and other cardiac output.
So you're right, absolutely. The old generation flow tracks, they were having this problem. They were not calibrated for septic patients, but all the generation 3 flow tracks, they have been validated very well in the septic patients also, and the accuracy is reasonably well. I will not say as accurate as PA catheter, but a reasonably acceptable alternative to PA catheters or any other cardiac output monitor.
Correct.
So,
So,
please. So one point I like to add here. So we have used thoracic bioimpedance monitor in our unit, that twin cardiothoracic unit, and we tried to validate with the PA catheter. So our correlation was hardly, it's kind of 60 to 65%. So, and it was kind of, it's a little cumbersome to use in that cardiothoracic unit. 6 leads, that in a patient who already underwent the surgery, there will be 2 pipes, drainage pipes. So that was a little difficult. We used near about 35 patients. The result was not that encouraging, but I would like to listen from other people if they've used and if they've correlated with the PA catheter values.
No, we don't have any experience.
We have not used, to be honest.
No experience.
Yeah, that's a demo machine. Long back in 2017-18, it came to India, but nowadays I'm not seeing any center using it.
Also, the presence of pleural effusions, pericardial effusions, or a lot of lung water like ARDS will affect our values theoretically, right? So most of our ICU patients don't have these issues. So it limits the population in which it can be used anyways, if I'm not wrong.
Correct. So I think, can we bring an end to the discussion? And we have an important, very interesting session of 10 to 15 minutes waiting for us.
Yeah, I'll be quick for the next one. Already 97 minutes, isn't it?
Yeah.
And so thank you.
So Dr. Milind is going to just enlighten us and about the practice of critical care for the Indian intensivist in Australia. What is the scope and how one can go there and practice intensive care medicine?
So as I talked, I'm supervisor trainee here for more than 15 years. So I'll just briefly talk. I got plenty of trainees coming every year. Actually, in my unit, we get at least minimum 10 trainees a year, and there are so many units in Australia. And so there is huge scope for trainees who want to come to Australia from all over the world. And so the governance of the training is done by the College of Intensive Care Medicine of Australia and New Zealand, and all the units who are the training unit are attached to the College of Intensive Care Medicine, and unless and until that happens, that training is not recognized. There are some hospitals, some units, they may not be attached to the college, so they are not the training unit. Well, some units which are attached, they are the training units. That's a big difference between those two. So to become a trainee of the college, what college expects is the doctor will have the ability to achieve all the competencies and show all the values, attitudes and aptitudes required of a specialist in intensive care medicine. And then college allows each unit to go through the trainee selection process, and it's done by the supervisor of trainee and the colleagues. So the training time is minimum 6 years. Since 2014, the training has changed, and this is the current training program, which is the minimum of 6 years but often many trainees take longer than that. About 8 years is quite common, because it's the foundation training, which is 6 months before they start the program. So they have to work somewhere, then work in ICU for 6 months, and then when 2 fellows of the college, 2 consultants sign that this person is okay to enter in the training program, then only they can enter in the training program. And total training, it's then after that is 6 years. So that involves multiple aspects. The core training is the advanced training, actually. So it has to be after the primary exam. I'll tell in a minute what are the exams there. And the transition year has started, which is after passing the fellowship exam. And also training has to have 1 year of anesthesia, 1 year of general medicine, or medicine anywhere, in any subspecialty. Electives 6 months, which can be in intensive care or somewhere else. Then trainees have to go in the rural area for 6 months, and they need to have pediatric exposure at least for 3 months, could be accrued up to 6 months. This is for the adult training. This is what is required. And that constitutes the total training time. But also when they are doing the training, they have to pass the primary exam before they start the core training of 2 years, as I mentioned, the transition year. But other training they can do before the first part of the exam. So they can do 1 year of anesthesia, 1 year of medicine, just the core ICU. What we call is the basic training. And once they pass the primary exam, or the first part exam, then start the advanced training. That's the core training. The CICM second part, also called as fellowship exam, that's the key exam in intensive care unit. And trainees have to pass that exam to become the fellow. And this is considered as the tough exam by many people. Also, all the trainees have to go to the training evaluation reports on the regular basis. They have to go through the workplace competency assessment, observe clinical encounters. So nowadays, every 3 months, trainee has to present a case, and has to be up to the mark. Otherwise, their training is not accredited. The trainees who are before the 2014, they have to give at least 4 cases before they appear for the fellowship exam, which are satisfactory, considered satisfactory by the 2 fellows. Project, or also people call that thesis or dissertation, is the same thing, the formal project. Those are the requirements of the college. And during the 6 years, you have to have all these courses ticked off. They have to do all these courses: brain death, organ donation, burns, inhalation injury, cultural awareness, evidence-based medicine, focus ultrasound. That's what Dr. Guru was talking, is the focus. What they don't need to know everything, but the focus, cardiac ultrasound, neuro-intensive care, they have to go. Then transportation of patient, spinal cord, neuro and spinal, they have to do. Airway workshop, communication courses, and particularly breaking the bad news to the families, echocardiogram, ultrasound, and introduction to intensive care course, management skill. Management skill course has to be after passing the fellowship exam. Donor awareness, probably it comes in the brain death only, and ALS course, and probably we talked about that here. So all those courses they have to do, keep taking the courses as they go ahead, and one more thing I should say is when they are doing the training, so training has to be in decided unit. So they can't do all the training in one unit unless that training, the training center is approved for all the 6 years of training. So some of the big centers are approved for all the period of training, but many centers are not. So so according to that, all the centers, they are classified whether they are C6 unit, so or C12 unit or C24 unit, where they can do their core training of 6 months or 12 months or 24 months, and depending on that, the units are classified. Units are classified depending on their case mix, whether they have the trauma, whether they have got neuro, they have the cardiac, all those things decide what type of the unit it is. And ours is the C12 unit, and that means they can do all of these medicine, anesthesia, 6 months selective, and the core training of 12 months, not of 24 months. And then the most important thing is the specialist, international graduate. If somebody wants to come from overseas, if they have completed all the training, then so that involves complete training in their own country, and they're considered as a specialist in that country, then they can apply for the recognition of their training. And then there are two parts. It goes to the Australian Medical Council and then goes to the college. And the Australian Medical Council assesses their undergraduate qualification, and the College of Intensive Care Medicine assesses their postgraduate qualification. And if they find the training, whether it's comparable, and they divide it since it's not comparable at all, or whether partially comparable or substantially comparable. And then depending on that, each case is assessed individually, and depending on that, the college gives candidate report how much training they need to do, what training they need to do, and where they need to do the training. I also forgot to mention one thing. All the core training and transition year training is prospectively approved. So it can't be retrospectively approved. Somebody can't do the training and then get approved. They have to get the prior approval before they start the training. Each 6 months, they have to send that paperwork that's what they are doing for next 6 months. And this is the pathway. There are huge opportunities for the trainees to come. There are people who come from all over the world, many countries, India, Sri Lanka, Pakistan, Bangladesh, Egypt, England, Canada, America, almost everywhere, South Africa, European countries. There are many intensive care trainees, and now many specialists becoming as well from almost every country. So it's a huge diversity of the trainees and the specialists in, and that's what makes it Australian for those people. And that's what I want to say here. If somebody wants to ask the question, it's open for the discussion. Vishy is also there, one of my colleagues. He could also help if the questions come.
Yeah, so any trainee or fellows or DMD exam going students, if they want to ask any questions, so we'll be happy to answer your queries.
If somebody is already postgraduate and he is in DND or DM critical care from Indian universities, so would it be still validated by the Australian university, or would they get any exemption for their training duration as far as the further training in Australia is concerned?
Yes, so there are two aspects. One is what's their goal? Whether it's a short-term goal to come, It's called a short-term training. It's specially designed by the college for the people who want to just visit for 2 years and then go back. It's called a short-term training program. And then they don't give any exam or become the specialist in Australia. So that's one way. If they want to become the specialist, then probably this is the pathway. They have to get their degree assessed by the college. And yes, I would imagine if they have done prior learning, college will substantially approve their prior learning and give some of the exemption. I have never seen anyone who has got complete exemption. They still have to do some training, but there are very variable people have got from 1 year, 2 years, or 3-4 years approved as well. Many people who what you are saying like DNB or DM, who are the specialists in those countries, I would say they would come mostly either the partially or substantially compatible in the Australian system.
Okay. Can I add some more thing in case if somebody wants to enter? Apart from the college training, every candidate who wants to practice in Australia, any specialty for that matter, but especially ICU, you need to first have an English test done. The English test to be currently valid, that is within 2 years, depending upon which English test, IELTS you're doing or some other test you're doing, the AMC will have its specific how much marks or score you should take. That is compulsory. The second is whether they should also sometimes, it is better that they should do an AMC part 1, that is a MCQ pattern, because at doing a training and becoming an intensivist is one chapter, but entry and getting a recognition for registration for APRA. APRA is a body like Indian Medical Council. The APRA is a body in Australia which gives you registration to practice medicine. Without that, you cannot do any training. So to practice that medicine, you need at least some requirement that we have to follow that first. So anybody who's thinking, first ensure that you have got your English is qualified, getting appropriate scoring system, whichever the English you can do, IELTS or any other system there. It is available on the APRA website or Australian Medical Council website. It will be available. And plus, I would still prefer that it will be easier if you start doing the AMC part 1, but it is not compulsory, but it might be easier for you to get into and move into the Australia once you do that.
Process becomes much more easy. Otherwise, there can be a lot of hurdles if they have not passed the AMC. Yeah, I agree.
Okay, so that's fantastic. It would be good to have the training program, which is quite substantial and very extensive, evaluating the candidates. So it means you have to really prove yourself to be practicing intensivist over there. So I think it's a good choice for those who are interested to go to Australia and start practicing over there. With this, I think if there are no questions, can we wind up with the session? And
if somebody wants to, some candidate wants to be in touch later, also I'm in touch with Dr. Gunadhar, so feel free to contact Dr. Gunadhar, and he would be more than happy. He's one of the colleagues has come here who is training for our unit now here in Adelaide.
Dr. Subhas, I think Dr. Subhas was with us previously. I think he's now in Australia.
He's with us now.
Bye, Shorty.
So I have put my email ID also here, so they can be in touch with me or Dr. Achilles also. So
thank you. Thank you for giving me opportunity to come and talk, and I really appreciate. That's wonderful. I have really enjoyed. I have learned a lot from all the panelists.
No, thank you. I must say thank you, Dr. Milind Senab. You have been truly, inspirational, and you were very thorough with your presentation. I think delegates must have liked it most. And I must thank you again for your presence and the representation for this program. I also thank Dr. Guru. I think he's left just now, and his wonderful insights will always remain with us and will remain associated forever. I also thank Dr. Amol Kothekar, my former colleague during my training session. Thank you, Dr. Amol, and wish to see you again and again for such academic sessions. And Tata Memorial Hospital has always been a place for academics. Actually, a lot of research and academics goes there. And it's like, the aura over there is all full of academics. So thank you very much, Dr. Amol, for your wonderful presence and insights. And I must also thank Dr. Niranjan. We are from Apollo, so let us stay connected and let us have exchange programs, academic exchange programs more often than this. And I also thank my colleague, Dr. Aditi, for your presence and your insights on even non-invasive cardiac output monitoring, 2D echocardiography as a tool for monitoring cardiac output. And I hope I again thank all the delegates and the colleagues.
Yeah, Achilles, just information. Next week we have an interesting talk on the troubleshooting during the ARDS ventilation. It's on Friday, 7 o'clock. So I invite all of you to be a part and join the session. Thank you.
Yeah. And thank you to my colleagues who joined, Dr. Vishy and Dr.
Vishy. Thank you very much. Thank you very much, sir. And let's have academic exchange with Australia and India. I think we can make a difference. It is all trainee oriented, and it is in the best interest of these trainee. I think we should have more often such programs, and we'll all remain connected as well with these academic exchange. With this, I thank you all and stay safe. Bye bye for now and good night.
Thank you.
Thank you very much.
Thank you. Thank you all.
Thank you.
Thank you.
Thank you. It's wonderful.
Thank you.